So I would like to thank the organizing committee for the opportunity to present this paper. Remember, 2004, it was the first time that we presented ASVAL at the French Society of Phlebology. And 1 year later, thanks to Peter Glowicki, the ASVAL method, which is a saphenous sparing approach, was presented at the Mayo Clinic, where the stripping was invented. But what is ASVAL? ASVAL, in fact, it's a simple approach for the treatment of chronic venous disease. It's not a technique, it's a concept. And this concept is based on the ascending or multifocal evolution theory of the chronic venous disease, where we think that the reflux starts from the bottom of the leg, uprising to the top, from the smallest veins to the great saphenous vein, and later to the saphenofemoral junction. So the method consists to do the ablation of the varicose reservoir of the varices. You can do that by microphlebectomy, why not by foam, or by, maybe in the future, by endothermal ablation of the varicose reservoir. And the goal of the ablation of the varices is to get the abolition of the reflux on the great saphenous vein. So this is a conservative approach for the saphenous vein. We call that the ASVAL for ambulatory selective varices ablation under local anesthesia. Many papers have been published since 2004, but the results published about the ASVAL method are limited to short or mid-term. So we wanted to evaluate this method at long-term or follow-up. So we did a retrospective study where we consecutively included all patients with varicose veins which were treated by ASVAL from September 2003 to September 2005. And the main inclusion criteria were the reflux limited to the great saphenous vein. Here is the design of the population. As you can see, there is nothing specific. 359 ASVAL procedures have been done, mainly in female patients, belonging to a low CYP of the CYP classification in 90% C2, C3, and symptomatic, these patients were symptomatic in 63%. Of course, we found a reflux on the great saphenous vein in all cases, with the mean great saphenous vein diameter of 6.8 millimeter. And we perform microphlebectomy in all cases under local tumescent anesthesia in outpatient fashion and with no concomitant treatment. Here are the results. We observed a total abolition of the reflux at 1 year in 71%, and this abolition remains quite stable over the time, 64% at 10 years. On the same way, we observed an improvement of symptoms and improvement of aesthetics at 1 year, but this improvement decreased over the time to 69 and 65% at 10 years. On the same way, we observed the freedom of varicose recurrence decreasing from 97% at 1 year, and it drops to 68% at 10 years, while the freedom of redo surgery was 76% at 10 years. So at 10 years, we can say that there were no clinical recurrences in 68% and no secondary procedures done in 76%. When we did redo surgery procedure during the follow-up, it was mainly redo ASVAL procedure with very, very few secondary ablation of the great saphenous vein. My first comment would be to say that we were a little bit surprised to see a discrepancy between the long-term survival curves because we observed a continuous deterioration of the clinical results, as you can see on these curves, but with a relative stability of the great saphenous vein hemodynamics. So it could suggest that the natural evolution of the disease could be independent of the presence of the saphenous vein reflux, And this relative importance of the great saphenous vein reflux on the clinical deterioration is confirmed by the limited number of secondary great saphenous vein ablation done during the follow-up. Remember, we did mainly redo ASVAL procedure in the follow-up. And this observation has been already reported by Beemans in a recent paper published 4 years ago about ASVAL. And she said that we probably should not focus only on saphenous reflux, but also take into account patient's symptoms. And the presence of the reflux does not necessarily correlated with functional impairment or clinical disease. But our study has some limits. Obviously, it's a retrospective study, and we have a high rate of loss to follow up. But, it's a general problem, in fact, for the evaluation of any surgical technique at long-term follow-up. Because it's a non-life-threatening disease with little disabling, and patients are active and are moving from town to town, so it's very difficult to get the results and the data. The long-term follow-up, maybe it's an illusion because of the continuous emergence of new or less invasive techniques. So in conclusion, ladies and gentlemen, I would say that the ASVAL method provides very decent clinical and excellent hemodynamic long-term result for C2 and T3 patients with a very limited number of secondary saphenous ablation and even secondary surgical procedure at 10 years. The clinical outcomes appear to deteriorate continuously at long term despite less adverse hemodynamic changes. And this discrepancy may reflect a natural evolution of the disease more or less independently of the actual reflux. Thank you for your attention.